Thank you very much. So I think that you've had the appetizer, and I hopefully will be presenting significant information convincing you that the science is further than some literature would suggest. And I've spent the past couple of weeks combing through the literature, doing my own systematic review, and I was very, very convinced that when I started looking at the psychosocial effects of hearing loss in the elderly in 1979, there was nothing on this area. Having done this systematic review now, there is a lot. When I started in 1979, Jim Furman had hair. I had no gray hair. And we looked like Frank Lynn. And we've come a long way. And fortunately, hopefully, you'll see the compelling evidence that, that we're in the right space. Now, how do I advance this? Okay, good. So the first issue is hearing loss a chronic condition. And there are a number of different tests that we have to identify whether or not when a condition is a chronic condition. And I think the most interesting ones, which are not as obvious, is does hearing loss place a substantial economic burden on society? Not a lot of literature on that, but so that we have to look at. There is a large gap between development of evidence-based treatment, guidelines, and practice in hearing loss. There is a huge gap. Require complex response over an extended period of time from a number of health professionals. Definitely hearing loss meets that criteria. And hearing loss frequently goes untreated until more accurate complications arise. And as you'll see, so when moderate to severe hearing loss sets in, when we have the biggest issues. So hearing loss definitely meets the test of chronic conditions. So also chronic conditions are associated with, when we're looking at healthy aging and we're looking at chronic conditions, what is clear is that the goal in healthy aging, which has been mentioned here, is that independence is important, psychological well-being, successful life course transitions, self-reported health. And, you know, as the more chronic conditions you have, the more the negative effect on the possibility and the potential for successful aging. So what I've done is gone through the literature. I've gone on a nice journey. I've been to Canada. I've been to Japan in my literature search. I've been to Australia, Italy, the United States, and it's remarkable what I came up with. So most of the studies that I'll be covering today, because it was emphasized that I must do evidence-based presentations, so there is a lot of evidence, and in the 15 minutes that I have allotted, I'll be going very quickly, but hopefully you'll be convinced of the evidence. So there are a number of different samples that have been used across the world. The Blue Mountains Hearing Study in Australia, the Blue Mountains Eyes Study, the Survey of Disability Aging and Careers in Australia, the NHANES Group, the Epidemic of Hearing Loss Study, Medicare Beneficiary Study. All these different databases have looked at hearing loss and its consequences. And they've all looked at these different correlates, and hopefully by the time you're finished, you will be convinced that we do have to figure out how to treat and address hearing loss. So interestingly, I was most impressed by the homogeneity in the outcome measures that people are using around the world. And I was touched to learn that the questionnaire that I developed in 1982 after I did my dissertation is the most widely used questionnaire to measure the functional effects of hearing loss in the elderly. So most of the studies throughout the world used a disease-specific measure of hearing loss, the Hearing Handicap Inventory, translated in every single language you can consider. The generic measures, in most of the studies that I'll be talking about, use the Health Outcome Study SF36. Most of the studies that I'll be talking about use the Center for Epidemiologic Studies Depression Scale, and most of the studies that I'll be talking about used ADLs and IADLs and ADLs as their functional status measures. So the first question that I'll start with, following up on Alan's presentation, excellent presentation, is in the area of functional disability, because functional disability has a heavy burden in terms of cost, and the issue of whether or not hearing loss relates to it is an important one. How we measure hearing loss matters, and the research that I've reviewed, this is one study out of Australia, and I'm not going to go through the, and on these slides I have the number of subjects in different studies, but since I have a number of studies, I'm not going to be able to talk about this, but I will say that this study had over 600,000 people that were surveyed in Australia, and about 21% of the individuals had a hearing loss, self-reported hearing loss, and about 14% had a self-reported functional communication problem. And these people were asked to rate the order of the problems that they felt were limiting their lives and were problematic for them. And the third one that came up was hearing disability, self-reported hearing disability in that population. But that's the only study that just didn't have that I'm going to talk about, that didn't measure hearing loss. All the other studies will measure hearing loss. So the measured hearing loss, however you measure it, we'll talk about, is really, really important. Okay, so here we have a study by Gopinath, McMahon. Now in Australia, they've done a lot of work. This is the Baltimore Hearing Study, and they've had large samples, a number of different cross-sectional, a number of different longitudinal studies, and what they did find is that measured hearing loss is associated with ADLs and IDALs, and moderate to severe hearing loss has the greatest relationship to ADLs and IADLs, but hearing loss of any severity is related to reduction in the ability to perform ADLs and IADLs. Hearing aid users were more likely to have impaired ADLs. Hospitalization risk, health burden of disease. This was, again, another study with Frank Lin and his colleagues. Genther recently came out, and they used the NHANES database, and they looked at burden of disease and hospitalization risk, burden of disease, number of self-reported physical and mental health problems over the past 30 days, hospitalizations, number of hospitalizations in the past year. And what they did find was that hearing impaired participants, mild to profound, were more likely to have a history of hospitalizations and hospitalizations in the past year. Hearing loss was significantly and independently associated with increased healthcare use and with burden of disease if you talk about self-reported hearing problems over the past 30 days. And then in another study by Gopinath, they too found that self-reported hearing, they found that self-reported hearing handicap was independently associated with low self-rated health in their population. Self-rated health is very, very important because it is related to mortality and a number of significant negative endpoints. So self-rated health is very, very important outcome measure that we should be focusing on. Okay, next is social isolation. And social isolation is an important area, and it can be defined in different ways. Lack of social contact or a more self-perceived subjective experience of lack of social connections. I became interested in social isolation when I took a course on aging and sociology in 1978, when I found that you can measure social isolation. So my dissertation was on hearing loss and social isolation in the elderly. I was discouraged from doing it because nobody else had looked at it, and at that point, most people were not really that interested in the psychosocial effects of hearing loss. Most of the literature in those days was on profound hearing loss and the effects of profound hearing loss. But I persevered because my mentor, Dr. Ventry, said not to. So what I did was look at at the time, I wanted to measure the relationship between isolation and how information is encoded, to borrow what Frank's description of hearing loss is. Also, I needed to have an estimate of how information is decoded. In those days, I didn't have that many tests available, so I looked at how measured hearing loss was related to social isolation. I looked at how auditory processing was related. For those of you who are audiologists, I used the Rush-Hughes Central Auditory Test. For hearing handicap, I used the hearing measurement scale because that was the best one available at the time. And then I used the monosyllabic words, W22s, because I knew it was really important to look at the different ways we can measure hearing, but I just didn't know what the right way is. And I used subjective and objective measure of social isolation. And what's interesting is that each measure of hearing was related to isolation. The strongest relationship was with the subjective experience versus the objective experience, and the strongest relationship was with self-reported hearing handicap. The next strongest was, in terms of auditory processing, the measure that tapped the cognitive load involved in understanding speech. The weaker correlation was with pure tone and monosyllabic word recognition. Interestingly, I broke my sample into isolation groups. The people who were most subjectively and most objectively isolated were the ones who had the worst measured hearing, had the poorest in terms of self-perceived hearing handicap, and they had the most challenges in terms of auditory processing. Interesting that I did all those measures, and interesting what you'll see later in terms of what we know now in terms of what hearing measures relate to outcomes. And then recently in 2008, another study from out of Australia, 3,000 participants, Hawthorne found that the likelihood of self-perceived social isolation increased with number of chronic conditions, and notably, depression had the strongest association with subjective social isolation, followed by self-reported hearing difficulties. Hearing difficulties came up before vision as a correlate of social isolation. Depression. Depression, as we know, is prevalent in the elderly. 15 to 20% of older adults do have a report of, have been diagnosed with depression. Like hearing loss, depression goes undetected and untreated. So it's one of those invisible chronic conditions. So McDonald did her dissertation in Canada on risk of developing depression and on hearing loss and hearing handicap and depression, and she used the CESD, and she looked at pure tone hearing, and what she found is that self-reported hearing problems using the hearing handicap inventory accounted for more of the variance in depression than hearing impairment, and there was a strong relationship. And in a recent study in Japan, Sato and colleagues, that was a pretty large sample, longitudinal. What they found is that odds of depressive symptoms were high as compared in people with hearing handicap as compared to those without hearing handicap. Hearing handicap, self-reported handicap using the Japanese version of the hearing handicap inventory was an independent predictor of depressive symptoms. Hearing impairment was not. So it does matter how we measure, and it's very important to look at hearing to make sure that we have all the measures available. So that they did conclude that Sato concluded that self-reported handicap does predict depressive symptoms in their Japanese sample. Again, Gopinath and their Blue Mountains hearing study and colleagues, they found that depressive symptoms were significantly higher in those with hearing loss, and there was an independent association between hearing handicap and presence of depressive symptoms. Falls, I think I'm not going to go into that because Dr. Jetty did, but I will mention that a study that was not mentioned was a study by Stevens, and they looked at a very, very large sample of Medicare beneficiaries, over 12,000. And they identified statistically significant risk factors for falls, and people who had high number of inability to perform ADLs, individuals with functional limitations, and individuals with depression were at risk for falls. But in their sample, interestingly, 30%, and in their sample, 30% of their people in their sample who were at risk for falls did have hearing loss. So hearing loss is quite prevalent among individuals who have reported falling. And in this slide, you could see 45% of the sample with poor self-rated health reported falls. 32% of the individuals with difficulty hearing reported falls. So it is prevalent. Falls are prevalent among people who cannot hear, and most likely and hearing loss is a risk factor, I would say, for falls, and that would be reason enough to screen everybody with hearing loss, with falls for hearing loss, if we have to go in the back door to screen. I'm not gonna, we spoke about the Finnish twin studies, just the possible mediating variables for falls we've touched on. It's hard to walk and talk because of the top-down and the bottom-up challenges. Also the fact that the hearing and vestibular mechanisms share similar structures, those could be mediating variables for the falls and the hearing loss. Okay, does hearing loss impact independence by increasing reliance on support systems? So that it would be a question about independence. And the reliance on support systems would mean if you need to use more family support, if you need to use more formal support systems, theoretically that would suggest that you would be less independent. And this was an interesting study. This was, again, the Blue Mountain Hearing Study. 2,800 people, about 33% of the individuals had hearing loss. Most of the studies I'm going to talk about the prevalence of hearing loss in the sample, about 33% hearing aid use, about 14%, which it is now. So that we have there's a theme in there in terms of the prevalence of hearing loss and utilization of hearing aids. What was interesting is that hearing loss was associated with increased use of community support and informal support systems. Hearing loss was a predictor of use of community support after 5 years. And severity of hearing loss mattered. Again, here we have people with moderate to severe hearing loss were at increased risk for the need to use community support services. Interesting, so people with moderate to severe loss had a higher risk of developing reliance on community support as compared to the hearing impaired. What was interesting is that the people who used the individuals who used the support systems were more likely to be hearing aid users. So you can interpret that one way or the other, but the use of hearing aids for their sample, the people who had hearing aids were at increased risk for the need to use community support services. Okay, mortality. This is kind of an interesting area, and I think it's a valuable area to explore as well. And this was Carpa and colleagues. Again, this was the Blue Mountain Hearing Study. And what they found is that in their sample, 33% hearing loss, the individuals with hearing loss had greater difficulty walking than the individuals without hearing loss, greater cognitive impairment, poorer self-rated health, and a higher probability of having diabetes. What they found is that hearing loss severity was connected to mortality, but it was through mediating variables, through walking difficulty, through cognitive impairment, and through self-related hearing loss. So it was an indirect relationship. And they used structural equation modeling, which in order to be able to highlight the relationship between hearing loss, mortality, and variability. And what you could see here is that there's not a direct pathway between hearing loss and mortality, but hearing loss is related to cognitive impairment, hearing loss is related to disability in walking, These are all related to self-rated health, so there's an indirect correlation with mortality through these variables. So this is why these are some of the functions that we have to look at when we're looking at the effectiveness of our interventions. Again, causality is not implicated here. Correlational does not mean causality, but this is an important association. Quality of life. So quality of life, when we think about quality of life, person's perceptions of health, social interactions, physical function, psychological function, all are important when we think about quality of life. And there are a number of studies. The Dalton study was with Karen Cruikshanks out of the Epidemiology of Hearing Loss study, amazing work that they do collaborating with the people in Australia. And Dalton found that self-reported hearing handicap, severity of hearing loss, was associated with reduced scores on the several domains of the SF-36. Hearing handicap correlated with more of the domains in hearing impairment, but both correlated. It's a very significant and convincing relationship. And also, hearing loss was severity of hearing loss was severity of hearing loss, severity of communication difficulties, as Jim mentioned. Communication is key, and hearing loss, communication are interrelated, and severity of hearing handicap associated with lower summary scores on the PCS and MCS version scales of the SF-36. Chia and his colleagues and their colleagues, again, that was part of the Baltimore Blue Mountains hearing study. Relationship between quality of life and hearing loss. Hearing loss, people with moderate to severe hearing loss associated with poor scores on the PCS, MCS scales of the SF-36 and 5 of the 8 dimensions. So moderate to severe hearing loss is really, when you get to that point, that's really when you really begin to measure and see the devastating and disruptive effects of hearing loss. But we also know from their work, people with both high and low frequency hearing loss had poorer scores on the SF-36 than people without hearing loss. People with both high and low frequency loss had poorer scores than people with only high frequency hearing loss, and only people with high frequency hearing loss had comparable scores than those without hearing loss. So it matters, the severity matters, the frequencies that are involved matter. 1 minute, okay. And there's a trajectory in terms of hearing loss and quality of life. And what we know is that from Gopinath again, over a 10-year period, the people who developed incident hearing loss were much more likely to have reduced quality of life. So the value of hearing aids is, I want to end on a possibly slightly, potentially up note, but we have work to do. Hearing aid use correlates with perceived need for improved hearing. Hearing aid use correlates with feeling disabled by hearing loss, and hearing aid use relates to feeling of being limited in terms of the ability to participate in society, which Jim mentioned. Hearing aid users, the value of hearing aids in these different studies that I talked about, many of the people did have hearing aids and they wanted to know what the effect of the hearing aid was. And what they found is that hearing aid users utilized and needed more support services. Over time, people who had hearing aids had less of a decline in quality of life than non-hearing aid users. That's good. Slightly better scales on the physical scale of the SF-36, and less of a decline in vitality than non-hearing aid users. So I wanted to kind of leave on a good note, in that hearing aids do have some sort of an effect. And what we know from Hogan, again, his 600,000 sub-study of 600,000 individuals, hearing aid users had better quality of life than non-hearing aid users, but they had a poorer quality of life relative to the general population. So what I'd like to conclude with is proposing a model here that the person-environment-fit model might explain in part the relationship between hearing loss and many of these different functional and psychosocial effects. And we have work to do in terms of future research. Just two suggestions. What are the absolute and relative risk reduction is important in public health, and how much is absolute risk of hearing-related consequences reduced with hearing interventions? Horizon to benefit. What is the length of time needed to accrue a clinically meaningful risk reduction in health outcomes associated with hearing difficulties? Geriatricians are concerned about horizon to benefit. And just conclude, the ability to hear, communicate, and understand really matters. Thank you very much.